and I'm excited to officially start today's institute with our first presentation on ancestral innovations at the crossroads of providing maternal health care with Nicole Gonzalez. And I'm honored, you can go stop sharing, Don. So I'm honored to introduce Nicole Gonzalez, who brings a wealth of expertise and knowledge. Nicole Gonzalez is a nurse midwife from the Navajo Nation. She is the founder and health policy director of Changing Women Initiative, which has the mission to empower diverse Indigenous communities to protect cultural resiliency and the fundamental Indigenous human right to reproductive health, dignity, and justice. Nicole is internationally known as a leading Native American maternal health expert who uses her knowledge, skills, and wisdom as a nurse midwife to inform innovative changes to maternal health policy and community wellness. She presently serves as the board treasurer for the Groundswell Foundation with the years of experience in organizational development, fundraising, and leadership development. And Nicole is now the CEO of Transcending Strategies, LLC, which works towards systems change in maternal and reproductive health, personal leadership development, and Indigenous health policy reform. So I'm very excited to have you here today, Nicole. I'll pass it over to you now.
Hi, yate everybody. Nicole Gonzalez Neshe, Glashi Nishlinto, Tochini, Bashishi Nishkaisui Deshache, Nanis Deja Deshanele. I'm Nicole Gonzalez. I am located here in Albuquerque. Pretty excited to present to you today on a topic that's important to me, and I know a topic important to many people. This is intended to be an 1.5-hour presentation, so I'm going to do my best not to actually get through it in a short period of time for you all. I've had the honor of presenting this topic to the Kaiser Permanente providers in California, so it's some really good content in regards to what we're talking about today. Let's see if I can do a slideshow. Okay, there we are. So the topic obviously is ancestral innovations at the crossroads of providing maternal health care. I've been a nurse midwife for, I want to say 11 years. And so I feel like my work intersects in a lot of different ways. I consider myself on the path to traditional healing. I worked a lot with medicine folks in regards to healing work, body work, and not just in the Southwest, but in Hawaii and other countries. So I try my best to weave traditional wisdom with obviously Western medicine. And really that's kind of a bit of what this presentation is about. My hopes after your presentation, my presentation, is that you'll have measures to reflect on community ways of knowing, and how this increases your capacity and competence in understanding diverse communities, which we have many, and identify innovative strategies for serving populations, rural, underserved, low resource areas, which many of our communities are this. And then just self-assessment and cultural competencies. I know we're all Native Indigenous, but we're not a monolith of tribal information. So always great to hear what each other's community is doing, and also different perspectives and worldviews when it comes to maternal health. A question I want to start with is why we're here. A lot of us start on our path, whether it's midwifery or physician, MD pathway, social work. And the longer we do this, we kind of can lose track of what our purpose is and why we're here. And it's important to also reflect on like what kind of knowledge we bring forward from our backgrounds. And beginning this conversation around our knowledge and where it comes from, understanding our history of Indigenous people and how we're weaving that through the work that we do. Sorry, this way. And this, for example, is just an example of birth in Ohogan that I've had the pleasure of attending in the last 2 years, and bringing obviously some Western medicine training that I have and other birth attendants have, but still having a traditional birthing setting where the baby is coming forward. Another perspective to consider is the human rights. Because we're Indigenous folks, we're always under the attack around our identity and our rights to our land, especially as women. as individuals, the rights to our body and the rights to birth in a respected way in our homelands. And so human rights is an intersectional issue that we deal with. I don't think a lot of people think about birth as a human right. And unfortunately, some of our reclamation processes in our communities leave out birth is because I think there isn't any understanding of where birth used to happen or how it affects our future generations. And that actually there's an ongoing fight to birth with respect and with dignity in our home communities right now. There are a lot of threats to birth right now. Patriarchy, white supremacy, misogyny, transphobia, economic inequality, sexual health inequalities, like these all take a stab at our right to birth, our mother, in a way that feels aligned with our traditional teachings. I think it's important to understand our history when it comes to where we birthed and how we birthed, and that how the policies affected where we can have our babies. So one would be, US policies that forbid our Native American traditional midwives from birthing in their communities or working in their communities as a midwife. Systemic removal of Native American children from our families, that's ongoing. Economic destabilization of Native American tribes, and policies that pressure tribes to identify tribal identity enrollment, often based on eugenic blood quantum practices, which is an issue today. History of forced sterilization. So we know in the 1960s and 70s, Indian Health Services sterilized our women. To this day, we don't have an apology. We have research and information that we know happened, there's stories. And then also just a huge push for LARC systems. As someone who's worked in private hospitals where there's mostly white populating people, they don't push the IUDs as much there as they do in our Native communities. So there is a disparity there. Unethical testing of oral contraceptive. So in Puerto Rico, in the 1960s, women were unknowingly tested for contraceptive pills, and some people died unaware of what they were taking. And then little or no data on Native American health outcomes, especially when it comes to maternal health. So there's like a data erasure of Native people, even though there's new emerging information, there isn't a foundation of where we started. And then also understanding like all of these factors affect kind of our birthing outcomes. If on the outside, we see preterm birth, low birth rate, suicide, sepsis, pneumonia, homicide. And then of course, on the maternal, we see obesity, violence, substance abuse, homicide. Some of the underlying issues that you don't see is loss of traditional foods and religious outlaw and blood quantum issues, sterilization, displacement, missing murder, Indigenous women, stress, environmental toxins, poverty, employment, like these all are one issue that we don't always we experience in our community. And we know our underlying issues for what we see on the visible side, especially when it comes to our statistics. And then also important, this colonization of maternal health care. Maternity care development has occurred around the world as a colonistic patriarchal model that assumes that the Western obstetrical model is the only truth, and that the knowledge of contributions of traditional midwives is worthless. Physicians hold most power, patients less power. So there's this imbalance of power that happens, which is perfect for obstetrical violence, which many of our community members experience in their birth experiences, and maybe don't report, but talk amongst ourselves. And there's also this really clear marginalization and eradication of our cultural rooted birth practices for healthy, normal birth. And so this is an intentional process that happened with the implementation of hospitals, with a licensure of midwifery, with a licensure and regulation of physician provided care. A lot of our communities shifted from birth on home to hospital setting, and this is part of that. Now we know that 90% of women birth in hospital, Native women, There's very limited traditional midwives and birth attendants. A lot of people went underground. We know there's this really interesting intellectualism that happens to validate our information, especially when it comes to our reproductive information as women. And it really undervalues our authority as women over our bodies. Settler colonialism has transformed gender in our tribal societies. What I mean by that is even basically saying like male, female people are the only one recognized as a married couple, defining gender and what kind of services are available, that now our tribes are implementing these practices as part of their legal and policy process. So that actually manages, it undervalues our ideas and traditional values when it comes to our sexual identities. Controlling where and how Native American women birth is actually a measure of control and surveillance work. And what I mean by that is if we can only birth in hospital and we don't have enough Indigenous birth attendants and birth workers, this really falls into line of like, what are the first things that our baby get when they're born? Social Security number, they get introduced into a system immediately, and that happens in the hospital setting usually. There's also just this sets the setting for perpetual power imbalance. So birthing people targeted to accept contraception planned before the delivery or shortly after their babies. Teenagers targeted for an immediate depot implant before hospital discharge. Coercive providing counseling pressure patients to accept intervention. Maternal infant tools, including race ethnicity-based factors. So like if we're talking about VBAC, are they studied on Indigenous folks? So we're like, is that good information for our population? Western specific intellect valued over traditional wisdom. Are there appropriate translators for people who work in communities like Spanish as a primary language, or maybe our traditional language with our elders? Is there appropriate translator to be able to translate in English or in their language about a pathway or plan for healthcare? Ignoring patient level health literacy, allowing provider to implement plan. I see this happen a lot. So they don't spend enough time explaining the education around a healthcare plan or a measure. And we know health literacy is an issue in a lot of our communities. People are not always aware of their own health or the ways to manage it. And so providers sometimes know this and may not provide all the options or spend enough time explaining thorough options, and will implement a plan based on what they feel like they want them to do. And they ignore the patients, like what they feel like they need. This happens. I really appreciate the Indigenous feminist framework as a pathway through all of this. What I appreciate about Indigenous feminism is it acknowledges our place in our community as Indigenous women pre-contact. We had power positions, right? We had, whatever our sexuality was before them. It takes into account that there's a new narrative being written about how we are in our communities, because what's been constructed or what we learn about our history is that there's a sustained structure of violence that we've had to grow through, that shaped our nations and our families and our identities. But this feminist framework allows us to go back through and reclaim and understand how that's happened. What we know now is existing frameworks not working and not built on community individual strengths. So, for example, people who can't come to appointments, or they can't come on time, or they don't have childcare. I mean, things have improved, but oftentimes if people miss care or don't come to appointments because of distance or whatever reason, it's usually blamed on the community and the individual, rather than looking at the system that's providing a service to the community, and is that system set up to serve that specific community? Most often it's not. Power must be redistributed, so people's health autonomy as a human right should be acknowledged through the system and as a value of like we understand as a baseline that our community are these things, and that we're going to provide care and service with that as a center and a value. Intentionally shifting power to center the needs, experiences of those most marginalized. As I mentioned, like a lot of hospital clinics have like an 8 to 5 schedule, sometimes not open through lunch, don't have after hours. And that's really providing service and care specifically to a population who have maybe a 2-parent home, who have childcare, who have time off to come to appointments during the day, rather than catering to maybe a population where parents are individual, like single parents, don't have childcare, work at the Taco Bell or the McDonald's, and might have to come in later in the day. So being open through lunch, having longer appointments, being open till 9 p.m. or 8 p.m. so that people who work during the day can come in for appointments. That's what I'm talking about. When you center your community needs, you can make these changes in your system and the way you're providing service to serve the community. I believe when you make healthcare accessible to the most vulnerable, we make it accessible to all people. So oftentimes I find Native people, we know we have a history of trauma. The way we access care, I think sometimes is not always taken into account. So if we consider ourselves, or if the research you read considers us a vulnerable population, why are the systems that we're engaging not making it easier for us to get into care at the times that we would most often get into care? And also understanding maybe there's multiple sites we would get into care, or that we're not all living on a reservation to get into care, which is something I think a lot of us do know. So what are some transformative practices if you're wanting to make this shift, right? So maybe some of the things I mentioned are things you acknowledge in your own systems, and you're like, well, how do we shift out of that? I think one thing is really important is acknowledging historical and ongoing harms by healthcare. Is an understanding, because people don't understand that history. Understanding the root causes of inequalities. As I mentioned, that tree, right? We have all this trauma, this history that manifests on the visible side of things, like those things are connected. Honoring bodily autonomy for all people. People have the right to their own bodies, and that they should be asked permission when you touch them or you do anything, because that's their power. Create and affirm conditions for healing. I think sometimes we're so focused on creating a system serving so many people that the system that we're creating is not healing, it's more traumatizing. And so how are we creating a system of healing along the way as well? And super important, creating systems based on meeting the needs of the communities they're serving. Like that example I gave earlier about, being more available and open for people who have specific kind of jobs. I mean, for example, New Mexico is 75% Medicaid insured. A lot of the Native women that I see in my prenatal care practice work at McDonald's or Walmart. There are a few professionals who work 9 to 5 at a business office, but they don't always have the capacity to take time off to come to appointments. And so how are we meeting their needs by being open later, so when they're done with work, can come in for care, that sort of thing. Creating conditions for healing and transformation. These are just some ideas and ways to do that. So centering and integrating traditional and community views on health and wellness. I know a lot of our tribal health clinics serve multiple communities, and so it's you can't always have one way of serving people, but taking into account what are some health and wellness views, and how can they be integrated in regards to traditional foods, understanding the role of traditional foods as medicine. I think this is kind of a new thing that's been going on. I feel the last 5 years, maybe I've been out of touch, but there's definitely been more emphasis on like eating healthier, having access to food, and what kinds of food. Being aware that architecture and design of space feels safe for families and is intended to support. Because our families are experiencing trauma, PTSD, anxiety, depression, going into a very sterile, clean environment is triggering. So how do we create environments that feel homely, that feel comfortable? One example might be a suggestion I've made to a few people on Navajo Nation is like, why can't we do prenatal visits in a hogan? A lot of hospitals now want to have a hogan next to their facility, but they use it mostly for traditional healing or maybe teaching opportunities. But to do a prenatal care visit there actually would probably feel really good to families. And to have a fire, if you have a fire going, that feels like home, that it immediately brings their stress down. Not that hard. You don't need a lot of equipment to do a prenatal visit, but like you can change the location to do care that way. It's not that hard. Understanding the role of plant medicines and traditional healers, touch medicine. These are all support tools to wellness. A lot of folks might use some of these things already. Sometimes what I hear from providers who have very limited knowledge about these things, sometimes instead of saying, I have limited knowledge about these things, I'm not sure if they'll work for you. It kind of sometimes navigates people away from trying those for things. And I hope that providers get better in the future of like knowing where their training and skill set as a Western medicine trained physician or midwife or any type of healthcare provider ends and begins, and then where like plant medicine, traditional healer, allopathic medicine begins. So like if somebody needs a consultation with a naturopath or somebody who could maybe see someone's health in a different way that maybe pharmaceuticals aren't going to fix, like to be able to know that you can send someone to get this other kind of care and actually probably could make an improvement in their health. But what I hear sometimes providers say is like, that's not evidence-based, or I don't know if that's going to work for you. I think it's hard sometimes to be a provider and be like, I don't really know, but it's worth you exploring. Because we place so much value on people who have master's and doctor's degree in medicine, but they're trained in Western medicine, they're well knowledge about pharmaceuticals and all of those things. They're not so trained in traditional healing and plant medicines and allopathic medicines. And so just so people are aware what everybody's skill set is. Understanding the role that transportation plays in accessing care and how it can ease your burden. I know in many parts of the US, people can have issues with getting to appointments for many reasons. Oftentimes they don't have a car. If you work and live in a rural community, like that could be an issue. But this does affect how care can be provided. Back in a long time ago, doctors used to do house visits, and it was actually a better quality of care model. But because you can't bill for those services at home, or it's more challenging to do that, we've moved care into a hospital to see more higher volume of folks. But that also doesn't allow for our community to always access us to make it easier for them, because some of them don't have cars. And so thinking about maybe innovative ways around like the access issue when it comes to transportation. I think it's really important to create practices and policies that support informed consent and informed refusal. I've read a lot of informed consent forms, and it's really interesting how they can be tailored to really kind of lead people down to say yes to things. Maybe people don't read them. Same for informed refusal, like people are really, how would I say, intimidated into signing yes to things maybe they don't really want to. But having an informed refusal process is like I'm refusing and I'm aware of what I'm refusing. And I've been educated on my options, but I'm still refusing kind of thing. I don't see that happening too often. I know to a lot of home birth practices, midwifery practices, allopathic processes, they do have an informed refusal process. And so I think that's important to think about when it comes to your families in your community. Funding and support focused on areas of care that the community deems as important to them. I often see funding put at like obviously direct care services, a needed service, mental health services, a needed service. Some of these things are not funded by insurance. And so a lot of practices don't want to provide service that's not going to get reimbursed by insurance. But there are other services that your community would really benefit from that are not insurance reimbursable things. One thing could be like food, allopathic, again, like acupuncture, massage, body work. There's these other things. So if your community is like, these are important things as part of our wellness that we would love to have access to, making sure that your organization or your clinic or your community has funding specifically for those things that you know your community wants and needs and will benefit from. Just some pictures. One is a picture of myself and another midwife at a birth we did in a Hogan. Here's another with somebody birthing at home. Another amazing dad had a cradle board as he was preparing it for the birth of his baby at home. If you were living or working in an area that's underserved or rural, there's lots of really interesting ways to serve your community. Oops, I need to go back. And I like to call this idea a creative thinking and planning on how to serve a large area or maybe an area that hasn't been served in that way as off-roading. I feel like a lot of practices that I visited want to implement models that have been proven to work. And oftentimes if proven to work, these models are proven to work in other populations and other communities, but they've not been proven to work in Native communities. So it's kind of limited evidence-based information. I think having a budget or having a team and having a mindset as part of your organizational design to do creative work around providing service and care to a specific population that's going underserved is a valuable process. And so I call it off-roading because maybe you have specific knowledge in your community about specific problems and you're brainstorming ways to serve them, but maybe you implement some known things that work well, and you try them out for a bit to see if they're going to work. So one way that we've done this is this map is actually, it's changed, but we used to serve parts of Farmington, Santa Fe, Albuquerque. This is like a 3.5 hour drive one way or the other. So it's a big area to cover as people who are doing home birth or as midwives are providing service to this area. And so having to think about how we're going to cover this area is another off-roading way of thinking about problem solving. Especially if there's like technology challenges. So some of these places don't have access to internet. So if we do home visits in some of these spaces, how are we going to document the visit? So looking at the technology to capture the information if they're mobile is something we've had to figure out. And also understanding when we talk about resources and community, it isn't just technology and buildings and water, it's people. So if some of these areas don't provide birth services or people have to travel long distance to go to hospital, like are we creating and putting funding towards a birth workforce, like doula, birth assistant, lactation consultants, peer counselor consultants. A lot of these services are training that community can take. They don't need a master's degree. They don't need a bachelor's degree. They can be somebody in the community who's invested in doing birth work support and want to get extra training to be that. to be that resource in their community. There's a lot of good things that happen from this. So an example of this is we trained 40 doulas in Window Rock, Arizona a couple years ago. I can't say all 40 of those doulas are working as doulas, maybe 20 or I don't know, maybe 10 of them now are working as doulas. But they formed an organization called the Navajo Doula Collective. And that organization is run by Amanda Singer, and they have folks who sit on their board. And so they provide service in Gallup and Fort Defiance and Window Rock, and are now branching out to build services in other areas. And also are working with Dene College to get some doula education as part of the curriculum. So that's just a good example of like, we saw that Gallup needed birth services, or at least birth assistance services. I'm sorry, not services, but like resources. We brought a training there. The trainees took it to another level. And now they're doing awesome things. And that's what I'm talking about, is when we target communities that would really benefit from skills and knowledge, like how do we bring those to those communities and take the barriers away. I think it's really important, this last piece about building care and support for frontline workers within the organization. When I say that, a lot of us who work in our community social work, or midwives, or doctors or providers, or in some way we're engaging with the community on a daily basis. And we see lots of things, right? We see things that really bother us. We hear things that bother us. We might even feel not a lot of support from our community for the work that we do. It's a lot of stress to put on somebody, and especially if you're the one doing that work. And so if you're working for an organization that doesn't understand the trauma you engage in on a daily with your community, and then you have an organization that has a model that doesn't support your own wellness, that is what really pushes people to burn out, and they don't want to work in this field anymore. So how are we as organizations supporting our teams who work on the front lines? So I'm talking about implementing policies that support funding to go see a medicine person, that support flexible work schedules, that support mental health support, that allow for time if you experience something hard and you need time to process away, that you can take that time and go and deal with your emotions, and then you can come back to work. I think that is a huge part of what I don't see happening in organizations, and people don't feel supported because they have this really specific work schedule that they have to maintain to get paid. But if our frontline workers are not in a good place in their mind and their hearts, they're not going to be available to do work in a way that feels good to them. And also, like, their mental health could be going down. So I think this is the bottom one I would feel is the most important. If you're working in a community and you're wondering about how to support frontline workers. I think it's important to do some self-assessment when you're out there doing the work, especially if you're a provider or you're somebody who's in charge of providing information. We all have personal biases, blind spots created by our educational pathways. So what is our own awareness about where we are with what we know and what we don't know? Like, that's important. Being really aware of what kind of role trauma plays in our communication. So like how we communicate as individuals, how our birthing person or the people we're working with. Trauma is a really interesting thing. I know we talk about it in a past context, but it's alive and well, and we're all reliving it in one way or another in our relationships and our work environments. And when I say about the role communication plays, if someone is traumatized or can be traumatized or have issues with trauma, some of the behaviors that come on trauma might be inability to have like confrontation, or maybe being super confrontational, like it depends. Sometimes there can be issues with showing up on time to appointments, asking for help. So like, I think the assumption sometimes people make is we are all taught to ask for help, and that when we ask for help, our needs get met. So oftentimes people are traumatized, have some history of like, we don't know how to ask for help, and we have a history of our needs not getting met. So how do they get their needs met and somehow ask for help, right? So that's something, as we're working with folks, have to be aware of. Also awareness that this isn't them out there that causes harm, but that we are also part of that process. I see this happen a lot, especially with this like reproductive justice movement, any type of activist movement. People are pointing the other direction about what's happening. Even though I gave a nice little history, a little bit about how hospitals can function and can be harmful, that, you know, we are also part of the process of how we support the systems that are in place right now. So if we're either not saying anything or we're not working towards policy change or change in general, like we are also part of the problem, and that it's not over there that somebody else is going to fix it. Like we also have to do that work as well. I think a really hard one to sit with, especially as being a nurse midwife, and maybe you guys think about your role in your organizations, is if and how are we accomplices to obstetrical violence and perpetuating re-traumatization. I think it's hard to speak up and to stand up when something right isn't happening, or if you're unsure if something right isn't happening, to ask questions and to know how and where to go to ask questions. And I think because obstetrical violence does happen in our Indigenous communities, like how are we addressing it? And also those of us in the hospital care settings, if we're not speaking up against it, you know, are we also contributing to the violence that's happening? I think it's super important as healthcare providers, and any one of us doing community work, to continue to do our healing work from our past, because it definitely affects our work and our relationships, and how we manifest to do the bigger work, right? If we want healing for our community, if there's programs you want to create in your community to serve them better, like is there if there's internal trauma that or things in ourself that we've not addressed, like that does affect how we work and how these things move forward or they don't move forward. So continuing to do the internal work, I think, is a really important part of this. Understanding our how our ancestral history shapes our worldviews. Maybe a lot of us who are Indigenous are pretty aware of this, and maybe some of us are not, but like we're definitely always doing the work to weave what we know from our ancestral knowledge as Indigenous people into what we're doing. Like with this worldview that we have affects how we work and who we work with and where we work. Like there's always an underline of this kind of process of weaving happening. I think understanding culture is a fluid and constantly evolving. I hear people use culture, and I know when we talk about Indigenous knowledge, like culture is a language that we use to kind of explain that process, but like culture is a set of beliefs that people in a community might follow. So hospital has their own culture, medicine has their own culture, midwifery has their own culture, but as we engage each other, it's changing and evolving because we're learning. So as I think about us as Indigenous people working in these systems, because we have the worldviews that we have, we are helping that culture evolve because we bring a different perspective to those spaces. I definitely think we can honor the past and our future as we continue to do work by integrating our perspectives and understanding the role technology plays. I think sometimes those of us who have more skills and more training in a specific area can feel separated from our community because we have these extra skill sets. And it's a question of like, are we Indigenous enough? Do we still have a solid sense of like where we've come from? And I think the answer, I won't think, but I know the answer is yes. And so knowing that we weave those perspectives together to create new is important to know and be aware of. when I talk about larger systems, I'm not just talking about hospitals and government. Like, we understand larger systems include water and land and sky and other ecosystems that we as people, our spiritual beings, are engaging with every day. And that's what our traditional teachings share with us, that we are engaging these other systems and that our actions affect these other systems. Using relationship and healing as a multi-level intervention. So building trust and community with birth families creates a foundation for change, healing, and innovation. Being really aware that trust is our most valuable asset and power, not as just an Indigenous person, but as somebody in the community, knowing that that's something that we have to gain with each other, but that's our power as well. Remembering that we as birth workers can be part of the problem, but also part of the solution. So as we continue to do work on ourselves, we can affect those changes through our actions and not just our words. So as, like I said, we continue to heal and work on our stuff. As a healer, as a person, or as a birth worker, someone in the community providing service in some form, like how we behave does affect others around us. And then lastly, communities impacted most by colonization are in a state of restoration and are actively reclaiming pre-colonial identities that have been shaped by outside programming. So I see a lot of communities doing this, reclaiming their roots. Where do we come from? How did we come to be? What is our root language? This is happening with birth, specifically in our Indigenous communities. As our midwives heal themselves and choose the path of midwifery, they are also learning about all the tools and the healing practices that come along with that role, and are awakening the community to understanding how important the ceremony of birth and mothering is, knowing that it's been impacted by these other things like feminism and these sexual identities, like I'm talking about, only certain people can get married as recognized by the state. Like, those are colonial identities and policies that are enacted in our community. But understanding like how those things has affected our mothering and our birth practices as women, as birthing people, I think is an important awareness to have. The ways that we can shift power does start with policy, understanding what kind of policies in our community are affecting how things are working. Like, do existing policies reflect the values, the communities they're serving, rather than protecting the organization? I think that's an important question to ask. Can we reshape current policies? Because sometimes some policies continue to perpetuate harm. Creating and reshaping services to support those that are most vulnerable. So as I mentioned before, seeing the person as holistically with their entire lived context. So where they're from and what they're from. Are they drug seeking, criminalization? Like, those times, those are labels, but they don't really give to the extent of like what this person's gone through. Informed consent and informed refusal, like, this is important about health literacy. What are our practices around this? Creating diverse workforce that reflects populations being served. Like, do we have an array of people working for us who understand the history of our community and our land that would work in a system that's been created to serve them in a respectful way? That's what I'm talking about. Implicit bias training, I think that should be mandated for everyone. Implicit bias is just maybe like thinking about who is deserving of care based on your own perspectives. I know we get different people coming out of our communities providing service and care and come in with their own bias about how we parent our children, how we even behave as women based off of their own values. And that's where there's that, like, that judgment that can happen. And then the judgment affects how they educate and how they communicate and how they decide what services you're going to be available for. Like, that's what I'm talking about. Discuss terms of structural racism factors and how it impacts obstetrical violence, and especially in labor and delivery units and places where people are having their babies. Structural racism is like you go to the hospital and the hospital has their own policies on how they're going to manage things. An example would be maybe the hospitals decided to do a urine drug test on everybody who's admitted who's pregnant, right? They didn't consent them to it. They're just expose it. They're just requiring that they do a drug test. But we know unconsented urine drug tests for pregnant women lead to babies getting taken away or CPS people get involved. And I definitely understand there's a lot of our populations where drug addiction is an issue. But I don't feel like that gets at the issue of drug addiction. It's consenting someone to be aware that they're going to test for things. Like that's a structural thing that's put into a hospital setting without people's consent. That can be addressed. Individualizing care that takes into account trauma history versus following hospital policies, protocols. I think that's an important thing. You can shift power by figuring out like what kind of policies within the hospital setting. For example, like I think sometimes it's hard if people want to burn cedar or sage, and it's like a whole process of getting permission. I think now we're in a place of like, now there's a building or a space to do that kind of thing. But it's a simple thing to be to think about being able to do ceremony like that in a hospital setting. In our eyes, right, you can burn cedar or sage, but like the hospital has to make a whole policy or something around that. Like thinking about the process just to do that is kind of interesting if you think about the power situation, about who you have to ask to get that done. Engage in self-reflection of biases and potential group reflection of biases. I think that's another important about healing and growth, because these sort of things affect how we work together, how we communicate, the working groups we choose to work with. Like, are there unknown biases about how we think and how we are in community? Another shifting power opportunity is recognition as part of the construction of power. They may place shame and blame on our actions. So take your power back through self-care, self-reflection, stuff like that. And cultivating trust with patients and families, navigating system, be upfront with patients' rights, ability to decline care, limit exams, right to see who's present during delivery, right to ask questions. What else can be done in your institution to change and shift the power to support your community and what they need? So that's the end of my presentation. I really crammed a lot into a very short period of time. And I definitely can expand on all of this. I do lots of presentations speaking about some of these issues. I feel like they can be pretty broad, but also speak to kind of the nuances of what we see in our communities and questioning, like, what can we do to change things? I have some really good resources attached to my slides if you're questioning anything I said, and it being evidence-based, because it is. And yeah, I think I'm pretty done. I'm going to give it back to Alicia.
Oh, well, everyone is showing their love with reactions and notes. Rebecca had mentioned if you have a book and journal information or podcast recommendations, that they can provide more information regarding Indigenous birthing practices.
Yeah, I think because Rhonda is coming in after me, she's doing amazing work with her organization. They do lots of training and birth worker training. I know mostly up in Washington area, but she does travel as far as I know. You'll have to ask her. And then Alaska has some birth workers up there doing amazing things. The Navajo Nation does have a podcast about maternal health that they do. I mean, a lot of these things around maternal health for Native people, you guys can do this in your community. You don't have to look someplace else. It's just a matter of like, is it a priority? I think everybody's kind of addressing this in a lot of different ways. And the reason I'm started my consulting business and stepping away from my foundation that I founded is because I want to help tribes and communities reclaim some power and human rights over their childbirth practices, and to support Indigenous midwifery happening in our communities. And I'm definitely, I mean, my work is global at this point. And so if I'm working as a consultant because I want to help more people.
And we had a question. Oh, I forgot. Let me see their name. Oh, Cheryl had a question with asking about, with IBCLCs being a certification that is very expensive and requires college courses, how important is it for every tribe to have an IBCLC?
So there's also this other area called lactation peer counselor training that doesn't require an IBCLC training background. So Cami Goldhammer and Kimberly D. Morcells, they provide that in training to communities. So if you want that information, I'm happy to share it. But they do awesome work training community to be peer lactation counselors. And so it doesn't require all of that. If you want to up your level and do the IBCLC, you can, but they've been doing this training all over the US.
Yeah, and did someone try to unmute themselves for a question? Because I have a question. Okay, let me go move forward. So can you elaborate on how the strategies you discussed, such as utilizing birth assistance and community resources? Could you share some examples of successful collaborations or partnerships that have been instrumental in establishing the network of support and resources, especially in the rural and underserved areas you had mentioned?
Yeah, so like I said, when we trained the 40 doulas in Windarock, I want to say like maybe 10 of them kind of broke off and did their own thing. And I'll have to back up with them, but there's a few now that one's working fully in like Shiprock and doing doula support as full-time work. Amanda Singer's group in Gallup, what is it? The Navajo Doula Collective. They do lactation and doula support in Gallup on Navajo. And they're really getting out there and talking about maternal health on their Navajo Nation. And so if you bring these trainers to your community to do doula training or lactation peer counselor training, like you train up your folks, you know, and then they decide to provide service and care to their community based off what they learn. They either can decide to create a coalition if that's what they want, or a nonprofit if that's what they want, or if they just decide to do independent consulting as a doula or lactation person, they can do that as well. I think what I see when it comes to implementing these additional folks is definitely having a hospital or some organization nearby who wants to work with them immediately after they're done, so that they can be put into action to not just now learn the skills, but also now to apply them in their work. So that's an example of kind of like when we offered this training, and the doula group in Gallup started their own thing. So the two trainers we use a lot is the Kemi Goldhammer and Kim. They do the Indigenous peer counselor training. And then my dear friend, Melissa Brown, she does the Zacadewin Indigenous doula training. She's actually coming here to New Mexico next week to do doula training with our folks in here in Albuquerque. And they do certify folks as doulas, meaning they are certifying that they completed the 5-day training and they can now be a doula support person. But yeah, I think to make that distinction clear, but it's 5 days of training. I think that's possible.
Yeah, I love the shout outs with Cami. She'll be joining us later today. I know it's Indigenous Milk Medicine Week as well. So maybe with one more question, and we all know you're doing amazing work, and with your experiences, what challenges or barriers have been encountered when introducing ancestral innovations you shared into the maternal health care system, as you mentioned, using Western frameworks, and how have these challenges been addressed is my question.
You know, what I found is most hospitals I've engaged with and physician providers in the Western system are very open to this, us bringing our traditional wisdom and knowledge. They are equally interested in implementation. I think it also depends, because I know there are some states that are pretty racist, and maybe there's still a battle even just acknowledging Native people as autonomy and sovereignty. I get that. That's like North Dakota, South Dakota. I know those are kind of hard places to be. I would say that the most of the challenge I've faced in my communities around the work that I do and merging these perspectives, unfortunately, has been other Native Indigenous people. They always say, you know, your hardest, how they say, your own people are the hardest on you. So there's a lot of violence, unfortunately, in midwifery and birth worker spaces. I think the challenge with being a Dene person, and I have a master's degree, is that I'm too medicalized and I'm not Indigenous enough. I think sometimes those of us who pursue education get into this situation where we're assumed to be separate or different from our community because we have education. And so I would say that's the biggest challenge, and also re-educating our communities around their rights as birthing people, because we've birthed in hospital for so long, and that's where they're used to getting care. Like you go to the hospital, you check in, the nurse does your vitals, and you kind of hand over like, all right, I'm here, I don't have to do anything, you're going to do stuff to me and I'm going to have a baby. But when you're reintegrating a traditional model of care, midwifery service, or even medicine, traditional medicine, is people don't just sit there and do nothing. Like you have to come to your medicine man or person on time. You have to ask for help. You have to show up. Like they're not just gonna, you know, if you don't go see them and you're not there on time, they're not gonna call you and be like, where are you at? We had an appointment, right? They're gonna be like, well, you didn't show up. But that's the point about realigning the two perspectives, is as somebody who's trying to merge the two perspectives, is like they're having to re-educate community that they have to participate in care, that they have to show up, that they have to give permission, that we are navigating on their terms and their space, and they have the right to say no. And it's interesting reintroducing those things to people, because they're not used to having those given to them. They've always had them, they just want to wear.
Thank you so much, Nicole. Maybe one more question, and this leads into our next session from Cindy. It is great to hear of all the Indigenous doula trainings. Are there Indigenous midwifery training programs also? And maybe Rhonda can chime in.
I know Rhonda is going to talk about the work that she does with her awesome program. And I know with Changing One Initiative right now, we are, how do I say, we're starting to train doulas, or I'm sorry, starting to train midwives. And so we're trying to figure out a way to train them up without having to leave their community or getting through this really interesting process of becoming a midwife. Because I'm a nurse midwife and I have a master's degree, I have like 8 or 9 years of education under my belt, recognized by, you know, the College of Nursing and all of those things. The other pathways to becoming midwives, there's other ways, which I know Rhonda's going to get into because she's great at this piece. But there is interest and focus in training more Indigenous midwives, but understanding the different pathways to do it is, I think, one of the challenges. And then also there's a whole group of people and movement that don't want to be trained or don't want a license and don't want to be recognized and regulated. Like they just want to provide birth support as an Indigenous person, as a healer, which is a very different place and role than what we do. But I feel like Rhonda would be the best to speak to that.
Yeah, thank you. Well, thank you so much for joining us today, Nicole. I always appreciate learning from you and hearing about the great work you're doing for our communities. And I hope you have a great rest of your day.
Yeah. Thank you, everybody, for having me. Sounds like some awesome presentations are going to happen today. A little last minute presentations are always fun. Anyway, take care, everybody.
Thank you so much, Nicole. I'll talk to you soon.